And welcome to the Coding Corner Medical Coding Education. My name is Rebecca Broyles, and I am co-owner and educator for the Coding Corner. Today, we're going to be doing a presentation on cracking the code. We want to nail the details in orthopedic coding. The disclaimer, the CPT is a registered trademark of the American Medical Association. The information in this presentation is updated as of the current time. This cannot be used as an authoritative source and is only to be used for informational purposes. For the most up-to-date guidance, please reference the AMA CPT book that is most current to the time of your search. The presenter is not to be held responsible for misinterpretation of the information. Now, today we're going to walk through the most common orthopedic coding challenges, why they happen, and how to apply guidelines that keep documentation accurate and compliant. Orthopedics is one of the most complex specialties for coding, so mastering these nuances has a big impact on reimbursement and audit risk. Why orthopedic coding is challenging. Orthopedic encounters often involve multiple procedures, imaging, and hardware. Add in the global periods and bundling rules, and it's easy to see why errors occur. Understanding these pain points help us code more confidently. Most coding errors start with documentation. Laterality and fracture details are especially critical. Encourage providers to document the who, what, where, and how of every orthopedic encounter. Some fracture coding essentials. Fracture coding is one of the most error-prone areas. As I mentioned, ICD-10 requires a high level of detail, and CPT coding depends on the treatment method. Reinforce the need for precise documentation. We want to always identify the type of fracture if you're treating a fracture. You want open or closed, displaced versus non-displaced. Just to clarify, between those, open reduction for fractures, that involves making an incision to expose the bone, allowing for direct surgical manipulation and fixation using plates or screws or pins to fix the fracture. Closed reduction is treatment that is performed without making an incision. The healthcare provider manipulates the bone back into place externally. You also have percutaneous treatment, and that is treatment by inserting surgical implants through the skin. Like an external fixation device would be an example. As far as the fracture types, displaced fractures are types of fractures that occur when the bone breaks into two or more pieces and the ends of the broken bone are not aligned. This misalignment can result in a gap at the fracture site, which may require surgical intervention to realign the bone fragments. Displaced fractures can be further classified as open, where the bone pierces the skin, or closed, where the skin remains intact. Now, non-displaced fractures are characterized by a break in the bone where the fragments remain in their normal anatomical position. The bone may crack partially or completely, but the alignment is preserved, making it generally more stable and easier to treat. Another problematic area is the location, the bone, where it's at, the specific site, the laterality, left or right or bilateral, and the encounter type, initial, subsequent, and sequela. Now, initial, subsequent, and sequela, you have definitions of that throughout your ICD-10 CM code book. One example is on page 985 in the back of the ICD-10 CM chapter code book in chapter 19, the injury, poisoning, and certain other consequences of external cause codes. You have a seventh character A, which is for the initial encounter. That is used for each encounter where the patient is receiving active treatment for that condition. Doesn't have to necessarily be just the first time of treatment. It is each time the patient receives active treatment for that same condition. The seventh character D represents subsequent encounter. That is used for encounters after the patient has completed active treatment of the condition and is receiving routine care for that condition during the healing or recovery phase. Then the seventh character, S or sequela, is for any complications or conditions that arise as a direct result of that condition, such as scar formation after a burn or a problem in the fracture site or something like that, just a complication of that condition. You can use helpful hints. The Castillo classification for open fractures, that is a classification system that categorizes open fractures into 5 grades based on the severity of the injury, the soft tissue damage, and contamination levels. And this guides the treatment decisions. You can see an example of the different codes, the different seventh character codes that you would need for the Castillo classification also in the ICD-10 CM book on page 1079. It gives you the examples of the seventh characters you would use when the documentation supports. And remember, procedure codes depend on treatment method, closed, percutaneous, and open, and we've gone over those. Now, arthroscopy bundling rules trip up even experienced coders. Diagnostic arthroscopy is almost always bundled into a surgical arthroscopy. Always remember that open and arthroscopic procedures on the same joint are not separately billable. As you see on the slide, you can use modifiers when multiple compartments are treated, but not in the same area. Those wouldn't be reported separately. Joint injection seems simple, but imaging guidance rules are strict. If the provider doesn't document real-time visualization and needle placement, you cannot code the guidance. And you can see examples of how the joints are selected by size, small, intermediate, or major, in the CPT code book on page 130. The different classifications are in there, and there are different codes for each size, a small, intermediate, and major, and it gives you examples of which joints are classified as each of those areas and sizes. Global periods cause confusion, especially around E&M services. Modifiers are essential for showing medical necessity and separating unrelated care. Global surgical package issues, the global surgical package in ortho will include the preoperative visit, the postoperative visit, any typical postoperative care. You can use modifiers 24 if it's an unrelated evaluation and management service, or 25 if it's a significant separate evaluation and management, 57 for decision for surgery, and 79 unrelated procedure during a global period. Now, the global surgical package does not include a return to the OR for complications, any unrelated E&M services, or any new injuries or conditions. You would be able to code those separate if they were documented using the modifiers. Orthopedic hardware is another area where bundling rules matter. Removal and revision procedures must be coded carefully, especially when multiple devices are involved. Imaging is integral to orthopedics, but documentation must support the exact service bill. Radiology codes are very specific about views and contrast. Modifiers tell the payer the full story. Incorrect modifier use is a top reason for denials and audits, so accuracy here is crucial. And here you see a few, the RT, LT for laterality, which is right and left, 50 for bilateral, 59 or XS for distinct procedural services, 76 or 77 for repeat procedures, 22 for increased procedural services. These errors are common but preventable. A strong understanding of guidelines and consistent documentation review can significantly reduce denials. And here you see some top coding errors that can be avoided. Unbundling arthroscopic procedures. Know what's in the global packages. Incorrect fracture encounter coding. Missing imaging documentation. Wrong joint size for injections. Failing to apply global period rules, or missing or incorrect modifiers. Orthopedic coding is a team effort. Templates, education, and audits help ensure accuracy and compliance. Staying current with guidance updates is essential. Some best practices for success: use templates that prompt for required details. Encourage provider education. Perform regular internal audits. Stay updated with CPT and ICD-10 changes, and collaborate with clinicians for clarification. Now we're going to look at some case examples. Here's a distal radius, ORIF coding, open reduction, internal fixation. It's a 42-year-old with displaced distal radius fracture of the right, ORIF with volar locking plate performed. This highlights the importance of documenting fracture details. We have the displacement, the laterality, and then if you can document whether the fracture is intra-articular. CPT selection depends entirely on the fracture pattern. If the surgeon doesn't specify, coders must query them. And here you see the ICD-10-CM code is in the S52.5 series, but you would need to be more specific with the laterality and what other documentation supports. The CPT code is in the range of 25607 to 25609, depending on the fracture type. Knee arthroscopy. Meniscectomy with chondroplasty. You have a diagnostic arthroscopy, a partial medial meniscectomy, and a patellar chondroplasty. Now, arthroscopy bundling rules are strict. Only the most extensive procedure is coded unless a separate compartment is treated. This case reinforces the need to understand your NCCI edits, because you would see that the chondroplasty and diagnostic scope are bundled. Here is a glenohumeral injection with ultrasound. left shoulder injection for left adhesive capsulitis, ultrasound guidance was used. You see the ICD-10 CM code for adhesive capsulitis left, and the CPT code would be 20611, and that's based on the size of the joint injection. Now, in this particular case, understand that ultrasound guidance requires documentation of real-time imaging and needle placement. And if either is missing, you must code the 20610 instead. That is a common denial area. Hardware removal is coded per site, not per piece. Even if multiple screws or plates are removed, only one unit is billed unless separate incisions or sites are involved. Modifier 24 is used only when the evaluation and management is unrelated to the original surgery, and documentation must clearly support that this is a new problem. Here in this example, it's an unrelated E&M during a global period. You have ACL reconstruction done 3 weeks ago, and now the patient comes back with new lateral knee pain that's totally unrelated to the ACL reconstruction surgery. So the CPT code would be 99213, and you would add the modifier 24. So in conclusion, orthopedic coding is complex, but it's manageable. Accuracy depends on documentation plus guideline knowledge. And reducing errors improves reimbursement and reduces audit risks. With the right tools and understanding, orthopedic coding becomes far more manageable. Thank you for watching this video on orthopedics today. You can find more videos on our YouTube channel and by visiting www.thecodingcornermce.com. Thank you.